people over 80, it's 15 to 20%. So it's definitely affecting the older population disproportionately.
We need to prevent curves, and preventing the curve of suicide, depression, and mental illness is a consequence of this situation across the age span.
The elderly who are frail and living in long-term care are living under social conditions that will promote and make them more susceptible to developing COVID-19 symptoms.
From the Zoomerplex in historic Liberty Village, the Zoomer with Libby Znaimer.
Welcome to the Zoomer. I'm Libby Znaimer. COVID-19 has affected us all, but older Canadians in particular have been hit hard by this pandemic. Nearly half the deaths here in Canada have occurred in long-term care homes. The virus of ageism that has accompanied this disease is equally pernicious. From the viral hashtag Boomer Remover to the U.S. Lieutenant Governor's suggestion that older people should sacrifice themselves so Americans don't, quote, lose the whole country, to a tweet from a Canadian MP suggesting that the economy should be reopened since most victims were in nursing homes and have short life expectancies anyway. We've gathered a group of experts to discuss how ageism has played a part in this pandemic. But before we dive in, let's tee up the topic.
In the age of coronavirus, ageism is alive and well. A recent column in The Telegraph concluded that an economic silver lining would be the culling of seniors and the disabled. On social media, thousands think it's funny to call COVID-19 the Boomer Remover. And reports from Italy tell of doctors forced to make decisions about which patients are given a chance at life based on age. These examples underscore a fundamental truth of ageism, that it is pervasive and condoned in our society. Worse, its impact could literally be a matter of life or death.
From the beginning, we've known that older people are especially vulnerable to COVID-19, but so are people with other comorbidities like diabetes, heart disease, and obesity. So why the razor-like focus on age? Dr. Liu, what's your take on this?
When you look at the mortality rate, there is definitely an increased curve amongst people that are older. So if the mortality in the overall population is about 0.5%, and then you look at people over the age of 60, it increases to 3%. People over 70, it increases to 8%. And then people over 80, it's 15 to 20%. So it's definitely affecting the older population disproportionately. And as a group, it's easy to identify these individuals. Older people are visibly identifiable as opposed to some of the other groups that are affected, diabetes, heart disease. Those things are not visibly identifiable in terms of a population or a group.
Dr. Buckman, do you agree with that it's because they're easier to see than, say, somebody who has diabetes or heart disease?
Yeah, those are, like it's been said, those are hidden, what we call comorbidities or other illnesses that older people tend to have. The majority of people of over 60 have at least one additional comorbidity. So it seems that with COVID-19, those people that suffer from these additional conditions, such as heart disease, asthma, chronic obstructive lung disease, are more at risk of suffering the symptoms and the worsening prognosis with COVID-19.
Greg, in your view, does the focus or the fact that older people are more vulnerable in this, did that lead to ageism?
Certainly does lead to ageism. You've only got to listen to some of the comments made by people in this country, in the United States, how older people should look at sacrificing themselves. And that's really the wrong emphasis or even thoughts to be thinking about. Older people still have a lot to contribute. And I think it's easy to focus on older people as being the largest percentage of people being affected by COVID-19. But we lose sight of the fact that it's impacting a lot of other people as well, and people without underlying comorbidities. So I think older people are being a bit of a scapegoat in terms of the discussion around this particular disease. And I think a lot of it could have been mitigated a lot better and earlier if we had decent practices in place from day one.
Roger, do you agree with that older people are being somewhat scapegoated?
Well, I think that the data are reading out very clearly that our older citizens appear to be at greater risk of mortality due to this virus. One other point I wanted to flag, though, Libby, is that we know from a separate body of research that older people are more likely to rate themselves as extraordinarily lonely when compared to people in middle age. This is before COVID-19. And there's a scientific literature emerging that loneliness as a subjective rated outcome itself is associated with premature mortality as well as suppressed immune systems. So I think there's actually several factors that are really, sort of mixing together here. But I think it's not just age. I think there's a racial issue here as well. We've been hearing largely from the US, African American, and certainly in New York, also Hispanic populations, especially at risk. So I think, in fact, as we look at this with sort of a lens of sort of intersecting circles, we have age, we clearly have racial groups, and we also have socioeconomics. These things all interweave.
I saw a statistic that said, in terms of older people, an older person in a nursing home has a 10 to 20 times greater chance of a very serious case or of dying of it than a person the same age who's in the community. So with older people being lumped in together, I mean, for instance, the recommendation is that everybody over 70 has to shut themselves up and never go out. I mean, was that useful or is that a problem, Dr. Liu?
It is useful because older people do have increased vulnerability because of physiologic changes as well as that affects their immune system. But all older people are not the same. It's a very heterogeneous population. And so when you think about the nursing home population as opposed to people the same age living in the community, they have a very different health profile. They have a different level of frailty, different levels of comorbidities, and those are the variables that contribute most significantly to the risk of them having a bad outcome. So not all old people of the same age have the same health status, and that's what's the most important variable.
Okay. Coming up, did ageism lead to complacency? That's after the break.
25% of the people that were in hospital in Italy were under the age of 50. So the point that they are, in fact, at risk as well is an important one.
Welcome back. The emphasis on age during this COVID-19 pandemic prompted many young people to ignore the warnings and the guidance from health authorities. We all saw the mass beach parties during March break in Florida, as well as so-called corona parties in defiance of health experts' pleas to self-isolate. No doubt that contributed to disastrous situations in New York, New Jersey, and Louisiana. So was ageism to blame for the complacency amongst younger generations? Greg?
Absolutely it was. It's not going to impact me, so I'm okay. I can still socialise with my friends. And that was the attitude of many younger people when you saw them still going on March break. So it really did impact and attributed significantly to the spread of COVID-19. And I think it was irresponsible of the individuals themselves, but more importantly, irresponsible of government not to close down those, that put in social isolation measures much stronger earlier.
Oh, yeah, for sure. Dr. Buckman, do you see that as a contributing factor in the spread? I mean, public health authorities had to remind people, hey, it's not a cakewalk, even if you're young, necessarily.
Yeah, I think the message has to be clearer to younger Canadians that they are at risk too. I mean, it's the opposite of ageism in a sense, that these young people are not believing that they're at risk. They definitely are. But when it's put in that context, when we divide the young and the old, that's where I think the ageist theme comes out clearly. We shouldn't be dividing the young and the old. We should be looking at people and their particular living circumstances, as well as their risk of having additional medical conditions, as we talked about. Some of the data that's coming out that's showing that people who are more vulnerable, those who are lower socioeconomic status, those people that are living in more close-knit accommodations, whether it's a subsidized housing for people with mental health problems, but in particular the elderly who are frail and living in long-term care are living under social conditions that will promote and make them more susceptible to developing COVID-19 symptoms. And that's a problem. We haven't really funded and supported long-term care and those facilities as we should have over many years.
David, what do you think?
Canada's fatality rate is 26 per million. United States, 72 per million. Even at 72 per million, if I'm one of those young people down in Florida partying, I can make a very rational case that says, if you've got to gather 1 million people before you have 72 deaths, I like my chances.
Dr. Liu, what's your take on this?
The beach parties that we saw during March break or spring break, I think part of it reflects a sense of invincibility when you're young, that this illness is not that severe, I can survive this. But in fact, 25% of the people that were in hospital in Italy were under the age of 50. So the point that they are in fact at risk as well is an important one. The other thing that we heard on some of the media streams was that people think about the older population as another group. So those young people didn't see it as themselves. They saw it as an anonymous other group. But then when some of the reporters actually interviewed some of those young people and asked them to think about, well, what if you get sick and then bring this home and it infects your parents or your grandparents, and made it personal and made them understand that this is something that could affect somebody that they know, that they love, you could see the look on their face that their attitudes changed somewhat, and then it became a much more personal thing. So when we think about ageism and discrimination, it's when a group is grouped together without an identity, without a personal relationship with people outside of that group, and that otherizing is really what I think is at the crux of the problem.
Roger, do you want to pick up on what Dr. Liu was saying, that it's when you kind of anonymize these groups that this type of thing happens? How did that happen in this pandemic?
For me, the way I looked at some of the behavior I saw on these people partying in Florida and so on, I mean, part of it's immaturity and irresponsibility, no doubt. In many cases, it is part of this health belief model and invincibility. And we see this in many types of health behaviors: smoking cigarettes, high-risk sexual behavior amongst younger people. This is not new. I think what's also potentially relevant is the concept of hypocognition. Hypocognition is a concept that was coined back in the early 70s by a psychiatrist named Libby, and really refers to the notion of just being unable to grasp the concept. In other words, people just cannot really understand the concept of viral transmission, risk, and be able to appraise all this. And for many of us who approach this with presumably formal operational thinking, we think, well, how can you guys not get it? But for many people, they just don't understand it. And there's a silent calculus that goes on in how we affect our behavior. And a lot of young people just simply are hypocognitive. They don't have the conceptual frame of what we're talking about. But I agree with Dr. Liu. I think, in fact, that when we look at ways to change human behavior, education is not enough. Education has been shown very clearly to be insufficient to change human behavior. We see plenty of examples: smoking, driving fast, alcohol, and driving, and so on. So there needs to be incentives, and one of the incentives is altruistic incentives that Dr. Liu spoke about as a way to change behavior. I also heard, in fact, a discussion around that time, people saying maybe we should pay these students to not party, which seems a bit bizarre. But actually, in fact, that's another way people have tried to incentivize people. But I think that I'm not here to campaign to pay them. I'm just saying that we need to find incentives. I think that the altruistic incentive, I think, seemed to work for a lot of people.
Okay. Coming up, the ethical dilemmas facing medical institutions and how age may play a role. Stay tuned.
An individual could be on a ventilator for many, many weeks, and many suffer a sort of post-ventilation decline in their quality of lives.
Welcome back. I recently spoke to Dr. Buckman and Minister for Seniors, Deb Schulte, about the criteria that will be used if life-saving equipment and treatment have to be rationed because of short supply. That heartbreaking situation played out in Italy, where doctors had to make gut-wrenching decisions. Both assured me that the yardstick here would be who is most likely to benefit, and age would not come into it. But I have questions because part of that framework is based on a U.S. work called Fair Allocation of Scarce Medical Resources in the Time of COVID-19. And it does stipulate some choices based on age. So, Dr. Buckman, I'll start with you. When I was reading that particular piece of work on the fair allocation, it said that maximizing benefits requires consideration of prognosis, and that includes how long a patient is likely to live if treated, which may mean, and I'm quoting here, giving priority to younger patients and those with fewer coexisting conditions. So doesn't that mean age will be a factor if it comes to that?
Well, yes. I mean, you can certainly make that interpretation, and I think that's realistic. Here in Canada, though, we've taken an approach that suggests that we will look at what a person's overall condition is. So it's really about an individual's prognosis. It is the person, their overall condition, and will they benefit from a ventilator? And doctors and the committees that will be set up to make these evaluations, which are just not clinicians, they will be looking at what will a person's life be after a ventilator. An individual could be on a ventilator for many, many weeks, and many suffer sort of post-ventilation decline in their quality of lives. Yes, age comes into it only in the assessment of prognosis, but it is not about age.
Okay, because but am I understanding that correctly? That in the American context, age is a factor?
I can't really speak to the American context, but I'm speaking to the approach that we're taking in Canada. That is really about an individual person's prognosis and how they will do, will they survive the ventilation, and what their quality of life may be post-ventilation.
Okay, because my understanding was that the Canadian Medical Association endorsed that brief in its entirety.
It endorsed the New England Journal of Medicine article that made these recommendations. It was using that as a basis for the recommendations, the guidelines that we have in Canada. We had a limited amount of time to get this out to physicians. Physicians were calling for it. Not every hospital has the ability to put their own guidelines together. They don't have an ethicist on staff that some of our larger hospitals do. So it was an attempt to use some evidence-based recommendations for this purpose, and hence age is not a factor, but it is looking at that person and their overall condition, their likelihood of benefit from an intervention like ventilation.
Dr. Liu, what's your point of view on having, I mean, we saw what went on in Italy, horrible. What's your point of view on those decisions?
Yeah, it was a frightening scenario that we saw coming out of Italy. In Ontario, there is a document also being prepared. It's in process. It has not been released as yet. I have had the opportunity to review a draft of it, and it does not include age as a specific criteria. It includes something called the Clinical Frailty Scale, which is something that we use widely in geriatric practice to prognosticate with respect to mortality, as well as the need for institutionalization in the future. It's been validated to be able to predict that across different age groups based on criteria that are not related to just age. It has to do with frailty and function. There are also many other criteria in the triage tool, and the triage tool takes into consideration not just the need for critical care resources in the context of COVID, but also for other diseases. There will still be other patients that will be needing that type of care in the event that there is a surge in the pandemic. And so cardiac criteria as well as prognostic criteria related to cancer are also part of that triage tool.
Greg Shaw?
You can't make decisions based on age. You really need to look at what is the expectations of the quality of life this person will have post-COVID-19. But one of the challenges, of course, is what we don't know is what will the impact of COVID-19 have on people post-recovery? What's the impact on lung capacity and lung function post-COVID-19? And we do know that there's some evidence that there is a diminished capacity for people after they recover from COVID-19. So it might well be that someone that has a good recovery with no diminished lung capacity would be a better save than one that wouldn't. How do you make that decision? You can't. Everyone's life is as important as the other.
It seems to me that there was a lot of focus, particularly at the beginning of this. Do we have enough ventilators? We don't have enough ventilators. If we don't have enough ventilators, we'll have to make these decisions. And I think that out there, certainly among lay people, there was sort of this idea that as long as we have enough ventilators, everything's going to be okay. But from what I've seen, the survival rate after being on a ventilator is very low. And even among the survivors, the life you have after that can be extremely compromised. I mean, what is the medical profession doing anything to make people aware of that? And how are you handling that, Dr. Buckman?
We, as a society, really have not yet had sufficient discussion with the public about what we call advanced care planning. And that really refers to the process of looking at what one values in life, what's important to you, what gives life meaning for you. When we get to these discussions, we start talking about what it might be like to be in an ICU and what it might be like after, if indeed you do survive. So, for example, if someone were to say that what really gave them meaning in life was to communicate with their family members, and they were to be a situation ICU where they might be intubated and unable to communicate with their family members for weeks or months, or even told that they may not ever be able to do so again, would that be a life worth living for them? And once they begin to think about this in a deep and significant way, they begin to see that maybe they're better off not receiving ventilation at all, and may choose a more comfort-oriented or palliative approach to care. So it's really important that we emphasize the need and how important it is to get advanced care planning going. Everyone should be doing it. There is an opportunity for Canadians to get information about this through speakup.ca, part of the Canadian Hospice Palliative Care Association, where they can work through the guide, and there's a particular guidebook that has them examine their values and these questions, has them reflect on it, and are able to come up with a plan that they can share with their substitute decision maker families, their physicians, etc.
Dr. Liu, you want to jump in?
Maybe in retrospect, we should have paid more attention and put more emphasis on prevention as the primary goal earlier on in this pandemic. And I think that that's something that's true in terms of our overall approach to health, is that we haven't paid enough attention to prevention. So when we were focusing on trying to build ventilators quickly, perhaps we should have been thinking about how do we access enough swabs and reagent in order to be doing more widespread screening, because the data from other parts of the world would suggest that those countries that have been more successful have done more widespread screening. And so balancing the sort of extreme high intensity, high complexity intervention versus the prevention side of things is something that we've always struggled with in our healthcare system.
Okay. When we come back, we'll discuss the emotional toll this pandemic has had on older Canadians.
older folks have lost other avenues of social support, for example, the ability to connect with their religious institutions and so on.
Welcome back. Many in the medical field say we are in for an echo pandemic of mental illness as fear and anxiety spread during this time of social distancing and isolation. Loneliness and isolation are already concerns among older Canadians, particularly those who live alone, and now find themselves unable to see loved ones in person in the midst of a pandemic that's been said to put them most at risk. Yet, I've also seen studies that suggest that younger people are the most at risk for anxiety because of this. Dr. McIntyre?
Well, the reality is that all groups are at risk, and with respect to the age as a determinant, there's no question that much of the research has been done on middle and older age people. And yeah, you talked about the anxiety. There's fear not only of virus, but there's also fear of economic security for many folks, including older folks, during this time. Yes, people have not only been, in many cases, socially isolated and or quarantined, but really, in fact, a lot of folks, older folks, have lost other avenues of social support, for example, the ability to connect with their religious institutions and so on. And there's a large body of literature showing that affiliation with religious groups, in fact, is in fact very much can mitigate risk such as anxiety and depression as well as suicide. The technology platforms have provided clearly an opportunity, but I would say that as a general statement, the computer literacy and technology literacy of the younger person probably would supersede that of the person over the age of 60, 65, and that hasn't been as easy for a lot of our older people. We should also emphasize that, we're talking about older people as a monolithic group, clearly it's a heterogeneous group. And when you look at individuals who are older, who have either chronic non-communicable diseases like obesity or diabetes, or people who have pre-existing mental illness like major depression, their overall resiliency is further compromised. So this has been an extraordinarily difficult time with respect to the stressor, and in fact, the effect it has had on the inability to access usual supports during these times.
David, on the other hand, I've seen studies that say that millennials are most anxious, and Roger brought up resilience and resiliency, and older people, have had more opportunity to develop some resilience. What's your thought on that?
I can remember, I'm old enough to remember 3-4 weeks ago, Libby, on your radio show talking about the people were worried that boomers were not taking this seriously enough. We're getting out there, and the millennials were having to talk to their parents about taking this more seriously. There's an immense body of literature that says people get happier when they get older. This is pre-COVID. So it's not all one size. There's a lot of baby boomers that I know, maybe I'm one of them, who are sort of semi-defiant about this whole thing. And there's a huge number equally who are lonely and isolated and shut in, particularly if they're in a long-term care facility, particularly people with dementia who have not been able to be communicated with properly as to why their children and grandchildren are not showing up. So I would just caution that this is an amazingly diverse range of responses, and it's very dangerous to lump it all in that old people are this way, younger people are that way. Millennials generally have a higher anxiety about everything, even before this. Boomers are a little bit more, fat and happy and life's good before this. And it doesn't just flip-flop automatically. It's all over the map, as was said a moment ago. It's very complex. One size does not fit all, and we've probably got a dozen different groups, each of them quite large, and each of them with very different attitudes right now.
Greg Shaw, what's your opinion?
It's very easy to underestimate the resilience that older people have, and to think that they're not connected or are lonely in all circumstances is wrong. I think we can't put them in a one bucket fits all. I know for many older people, they have more contact with their family now than they had prior to COVID-19. So it's not personal contact, it's certainly video, phone, and those types of things. But the resilience levels are probably much higher than the younger generation of today.
Dr. McIntyre, how do you feel about that?
My colleagues in China and I completed a survey of just shy of 4,000 individuals in the south of China, which included not just Wuhan, but areas surrounding Wuhan. And our aim was to determine the degree to which this event has impacted their well-being and measures of stress, anxiety, and depression. And to the point of age, which I thought was quite interesting, and we looked at people 18 and older, and we had no ceiling to the older, we found that, in fact, age appeared to be a risk. We found that, for example, younger people were reporting higher levels of anxiety and depression and perceived stress in reaction to COVID. But then we found something particularly interesting. As we sort of interrogated the data some more, we found that younger people spent a lot more time on social media. And once we adjusted for that, in other words, once we adjusted for the contribution of social media, it turned out there was no age effect. So said simply, what we found was that the higher reported anxiety and depression and stress in younger people could largely be explained by the fact that they were spending significant amount of time on social media. And there's a separate body of literature to show that voluminous consumption of social media is associated with negative health outcomes with respect to mental health.
Yeah, well, good luck with getting them off social media. We're almost out of time on this subject, but Dr. Buckman or Dr. Liu, is our system ready to cope with the mental health fallout, given that those services are in short supply to begin with?
So, well, I'll just pipe in that the access to mental health services for older Canadians has been limited, like access to mental health in general, but specifically for older folks. My concern, particularly in this crisis, is that given the isolation that older Canadians are experiencing, maybe for some the lack of familiarity with online resources, all that leads to them suffering alone. They're not able to communicate that much with their family. They're not able to get the professional help that they may require for dealing with anxiety or other mental health issues that they may be experiencing. And I think this whole crisis has exacerbated the chronic underfunding of mental health services for older Canadians.
Okay. We'll be right back after this short break.
And it took this COVID crisis to have virtual care literally explode. So the genie's out of the bottle.
Welcome back. More and more physicians are closing their clinic doors and are choosing to conduct appointments with patients online or over the phone. Hospitals have put the brakes on elective surgery and routine care for chronic conditions, as well as screening and other preventive procedures. Dr. Liu, will this pandemic change the way we consult with our doctors moving forward?
I think that it will change the way we do work in the future. It was starting to change even before the pandemic. There was a shift to more virtual care, and now out of necessity, it has been a very dramatic shift. I don't think we've figured it out completely, though. There are still some patients that ask to wait for their follow-up visit. They'd rather come in and see us rather than have a virtual visit, whether it's by telephone or by video conferencing. And the other thing that I've noticed is that when I do a telephone visit with somebody or a follow-up visit, it's much shorter than when they come into the office and talk to me in person. And I'm wondering to myself, what is missing? What has now been abbreviated in our interaction that we would normally have had when we were interacting in person? So I'm not sure that we're going to be able to do everything virtually in the future, but I think that the way that we did things in the past will change.
Dr. Buckman, are people taking well to all this virtual consultation?
At the CMA, we've been trying to get virtual care going for years, just completed a year-long task force with the report released in February outlining sort of the policy, the safety, the privacy issues, the governance of virtual care. And it took this COVID crisis to to have virtual care literally explode. So the genie's out of the bottle. There's no going back. All the governments are now across the country are supporting visit codes for virtual care. And I think we have an opportunity here to, especially for seniors, to assist them. Not only are many adept at using it, but increasing home care, nursing visits, in with technology and peripheral equipment that actually can do physical examinations. I can listen to a chest, I can get blood sugars, I can do oxygen saturation levels, blood pressure readings, of course. All that can be done virtually. And this actually reduces the hardships or challenges for seniors getting into an office. It reduces the expenses that they occur or their family members may occur being off work, travel expenses, transportation, et cetera, in getting in. So I think this is going to be something that is welcomed and we'll really see that change in the post-COVID era.
Dr. McIntyre, how do you feel about that?
It's probably going to accelerate what was already happening in the first place. And I can speak as a psychiatrist that, from the telehealth perspective, we've had, been doing this for a very long time. And it not only is going to be relevant from the point of view of, making things more accessible, but certainly for a lot of people, it's also deals with the stigma issue. A lot of people still find it, understandably, very stigmatizing to go to a psychiatrist. And so this has been yet another barrier that we've been able to reduce, that being this technology, a barrier to seek out appropriate mental health care services. So I hope that in the wake of this, that the acceleration continues. And I also hope that it goes back to what we talked about earlier, it frankly is woeful, access to mental health services in Ontario and Canada. And I hope if anything in the wake of this, there'll be some changes that will in fact align with what I think people are agreeing that mental health is a key issue for our population.
Dr. Liu, will virtual care work for people, say, who have dementia?
Usually in that circumstance, we need to have a family member facilitate some of that interaction with the telephone and the whatever technology we're using to connect, but it can be used for people with dementia. There are processes to do cognitive assessments through telephone or video conferencing. We're still in an early phase of understanding how to validate that assessment. And many of my colleagues still feel that they're reluctant to make a diagnosis through that mechanism without seeing the person in person. But, we're still early in the process of really understanding how to use that method of assessment. And I think it will change in the near future.
Okay. We need to take a short break. When we come back, final thoughts from our panelists. Welcome back. It's now time for final thoughts from our panelists, starting with Dr. Liu.
When we talk about ageism, the thing that comes to my mind is the language that we use. And I think that that's something we need to be very cognizant of with respect to older adults and not referring to them as the elderly or as a group. Similarly, within the group of older adults, those that are living with dementia are another subgroup that are often stigmatized. And the last thing I would say about language has to do with this pandemic and some of the language that we see being used in terms of using wartime and military metaphors, which I think is a potentially dangerous thing. It can excite people, but it can also and motivate people, but it can also create an enemy. And that enemy, is it the virus or is it the person with the virus? And we wouldn't want the people that are sick to be alienated further in this pandemic.
David?
Well, I think if there's a silver lining here is that this crisis is provoking a whole bunch of subtopics under ageism, from long-term care home policy to virtual medicine to attitudes and depression and reaction to the ethics of medical triage. So it's going to produce a whole bunch of changes in areas that were kind of just hanging there. And I suppose if you look on the bright side, that is one good thing that'll come out of all this.
Greg Shaw?
I would hope that the building standards in long-term care are totally revised and revamped after COVID-19. We can't have situations of 4 people sharing a bedroom. We can't have a situation of one bathroom per 25 residents in a nursing home. How can they mitigate COVID-19? They can't even mitigate annual influenza with the buildings that we have in this country today. Single rooms, single en-suites is the only way you'll mitigate pandemics or annual influenza in the future. So the governments have really got to step up and change the whole building structure of long-term care.
Dr. Buckman?
I'm thinking along the same lines. It's a tragedy what's happening to the residents in long-term care at this point in time in Canada. And this is not only just about COVID, it's about the long-term underfunding of long-term care. It's about the structure of these buildings. It's about the inadequate pay and salaries of the dedicated staff that look after the folks in long-term care. We need a whole restructuring, a renovation, a new approach to long-term care. I am hopeful that what will come out of this is improved funding and really looking at all the governance and the policies and the safety of people who are in long-term care. And I certainly think that the government's ears will be open to the advocacy that has already happened actually for a number of years, but will finally make a difference for people who are living in the long-term care facilities.
Dr. McIntyre.
This pandemic represents what could be one of the greatest threats to mental health we've seen in a lifetime, and perhaps even longer. Secondly, we never talked about flattening curves before 4 to 6 weeks ago. We need to prevent curves, and preventing the curve of suicide, depression, and mental illness is a consequence of this situation across the age span. I think, in fact, the call to action is what was already mentioned. We need to rethink the priority around some of the nursing homes and how they're configured. A place I worked for 2 years and saw many, many areas of improvement, which no doubt structurally are contributing to this problem. And secondly, this truly is the clarion call for prioritizing mental health and mental health access and services in the elderly as well as other groups.
Okay, that's all the time we have. We can't allow this emergency to become a breeding ground for a prejudice like ageism. Thank you for joining us. See you next time.